We're a great state because Tim Walz is our governor. So, talking about an update regarding managing amyloidosis, those are my financial disclosures. Talk a little bit about conventional therapy and being sure that you've got the right kind of amyloid. So, in terms of the therapies of amyloidosis we want to talk about, the principle started with the combination of bortezomib, cyclophosphamide, dexamethasone that demonstrated significant improvements both in patients who get deep response and patients who are diagnosed early. And so bortezomib became the backbone 15 years ago for the management of immunoglobulin light chain amyloidosis. Other proteasome inhibitors have also been used in amyloid, and I should just know, people ask why VCD and not VRD, and that's because lenalidomide is really quite poorly tolerated in the amyloid population, particularly if there's cardiac involvement, which is 70% of the patients. IMiDs make heart failure worse in patients with cardiac amyloid. You can put them on it, and you can see their New York heart decline, increased fluid retention, increased dyspnea. And so IMiDs in that population is generally not a good choice, and that's why VCD. But of course, ixazomib has the problem that it requires subcutaneous administration. So ixazomib has also been used as an all-oral combination in patients with amyloid. And ixazomib clearly does have activity in second-line therapy of amyloidosis compared with physician's choice. So it's an alternative proteasome inhibitor that you can consider. The genetics are quite important in patients with light chain amyloidosis because unlike multiple myeloma, where about 15% have a translocation 1114, it's nearly 50% in patients who have light chain amyloid. So if 50% have 1114, that should automatically trigger in your head venetoclax. And so for patients for second-line therapy that fail a daratumumab-based regimen, in the half of patients that carry the translocation 1114, venetoclax shows high level of activity with a high level of hematologic responses. And although in terms of peer review publications, it's case series, there are venetoclax trials, registrational trials underway looking at venetoclax in the management of patients who have the 1114 translocation in AL amyloidosis. Now, of course, daratumumab is really the most important development in the management of amyloid and is the only FDA-approved agent for the treatment of AL amyloidosis. And like all other agents developed for plasma cell dyscrasias, it starts in the relapsed refractory setting in phase 2, looking at relapsed refractory, but you can see that even in heavily pretreated patients, response rates early on were reported anywhere between 60 and 100%. Deep responses, because unlike myeloma where patients can have a PR and do okay for years, if you don't reduce the light chain to more than 90%, you're going to still deposit amyloid in the tissue with the circulating light chains that are there. And so daratumumab clearly showed single agent activity in the relapsed refractory, and that led to the Andromeda registrational trial, which was basically all patients who were therapy naive, who didn't have ultra advanced cardiac amyloid, were randomized to receive the standard bortezomib cyclophosphamide dex compared to daratumumab bortezomib cyclophosphamide dex. The bortezomib was given the way bortezomib is given in the community, once weekly sub-Q. Daratumumab the same way you give myeloma patients, weekly sub-Q 8 weeks, every other week 8 doses, and then after 24 weeks, every 4 weeks, to a total of 2 years of therapy. The primary endpoint in amyloid is response depth, hematologic response depth, because this isn't a disease of tumor burden. Average patient at diagnosis is 10% plasma cells. This is a disease of a bad M protein, one that will misfold and wreck your kidneys, your liver, your nerves, and your heart. And what the trial demonstrated is that the hematologic response rate triples with the introduction of daratumumab compared with VCD. And that, of course, is exciting to providers, but it doesn't have much meaning to patients, because to a patient, a hematologic response isn't what it's all about. These patients came to you with heart failure, nephrotic syndrome, renal insufficiency, progressive neuropathy, and having had a hematologic response is not meaningful. What counts is organ response. That's what makes them feel better. So a hematologic response that doesn't translate to organ response is not clinically relevant. But what you see is that cardiac response in AL amyloidosis is doubled in patients who receive daratumumab-based therapy. And in fact, these cardiac response rates increase over time because resolution of an amyloid organ syndrome is a time-dependent variable, and it takes a long time. For the kidney, it can take 2 years. For the heart, it's usually a year you see it, but it can take up to 18 months. But what's important is that the daratumumab-based therapy does translate into an improved response rate. Renal response is also doubled. That means a reduction in urinary protein loss. That means a reduced risk of end-stage renal disease and chronic hemodialysis, which of course is a very big deal for our patient population. When you look at genetic subgroups, daratumumab improves all patients, del13, which isn't very common in amyloid, but all genetic subgroups show improvement. Pomalidomide is used in second-line therapy of patients with amyloidosis, but pomalidomide, like lenalidomide, is poorly tolerated. Even a dose of 2 milligrams is too much pomalidomide in this population, and 1 milligram should be your starting dose. But having said that, you can see the grade 3-4 toxicities are substantial, and the progression-free survivals are consistently less than 2 years. So second-line therapy for AL amyloid after daratumumab, and if they're not candidates for venetoclax, we're not there yet, and there's a lot to be desired. Stem cell transplant is still used some in patients with AL amyloidosis, but it's primarily used in patients who fail to achieve a CR after DARA-based induction therapy, or that are treated and then progress within a year after stopping therapy, where consolidation with a high-dose melphalan in patients who don't have advanced cardiac involvement becomes a legitimate consideration. This is just some results that we published some time ago looking at stem cell transplant and the overall survival. And you can see that after stem cell transplant, if you get a CR, you can expect a median survival of 15 years. So it still has some application, but not as first-line therapy, only in patients who get a DARA-based regimen and don't achieve a response suppression of the light chain that you feel comfortable with. We can even do it up to age 75 with similar outcomes to patients who are younger, with a therapy-related mortality of 3%. So stem cell transplant is still considered second-line therapy, but what's next? First, amyloid-dissolving antibodies. KL101 has completed its accrual in patients with advanced cardiac amyloid, and this waterfall plot from blood shows that in patients who have advanced cardiac amyloid and receive the antibody, they develop cardiac responses. This is not approved, but we're just waiting for enough events to occur before it reads out. Bertamimab is a second amyloid-dissolving monoclonal antibody, and what it showed was that in patients with stage 4 Mayo cardiac amyloidosis at 9 months, survival was improved by 50%. And so this is a phase 3 trial that also has completed its accrual and has had sufficient numbers of events, and we're just waiting for the readout. So there is potential for amyloid-dissolving antibodies in conjunction with anti-plasma cell chemotherapy designed to reduce the production. Now we're actually looking at dissolving. This is the third monoclonal antibody. This is just starting phase 1, phase 2 trials. This is a radioiodinated antibody that started as an amyloid imaging agent, and you can see in the pictures uptake in the myocardium and in the kidneys, and now it's been, because of the radioiodinated label, being looked at as an agent to dissolve deposits of amyloidosis. So this is our current recommendation for AL amyloidosis from msmart.org. It's DARA-VCD with a goal to achieve a VGPR followed by stem cell collection followed by transplant. In patients who are transplant ineligible, it would be DARA-VCD for 6 months followed by DARA maintenance. And if you don't achieve a deep response, then you move to our relapsed refractory algorithm, which asks about transplant eligibility, venetoclax eligibility, and if none of those, consideration of pomalidomide, transplant, carfilzomib, and bendamustine. Now, I should just say what's coming is CAR T and bispecific antibodies. Like other plasma cell dyscrasias, myeloma, relapsed, BCMA-targeted therapies are highly effective in light chain amyloidosis. There are 2 actively accruing trials looking at anti-BCMA CAR T for second-line therapy of amyloid, and J&J has activated a teclistamab bispecific antibody trial for the treatment of light chain amyloidosis. This is a registration trial and is open for accrual. So we've got anti-plasma cell chemotherapy, DARA-based, amyloid-dissolving antibodies, and targeted immunotherapy, both CAR T as well as anti-BCMA monoclonal antibodies. So that's the update, and thank you.